go. Good morning. I'm Grace Fraze. I'm the FASD project coordinator for Northern Alberta with the Solicitor General and Public Security. And I want to welcome everyone to this morning's session with Dr. Jackie PAE and Dr. Carmen Rasmussen. Their session is on mental health problems in individuals with prenatal alcohol exposure, FASD. Before I introduce Jackie and Carmen, there's a couple of details I need to take care of here. We're using a town hall format in which you can submit questions for the speakers by email to cys.fasd@gov.ab.ca or by texting 780-405-3376. And Jackie and Carmen will respond to your questions. Now, all the sites have been muted at the bridge, so please be sure that your mics are also muted. If you have questions for the presenters, their contact information can be found at the back of your handouts. And also, if you're experiencing any technical issues during this time or during this presentation, please let your local site contact know and they'll follow up accordingly. We are really pleased to let everyone here know that today's session has 87 sites. Now, 12 are from BC, 5 from Ontario, 1 from Prince Edward Island, which we need to note is the first time they've been with us, so welcome. 12 from the Northwest Territories and Nunavut, 10 from SK, and 2 from the Yukon, and around 150 people registered locally. Education and training is a critical strategy in the FASD 10-year strategic plan that the Government of Alberta has continued to address through various initiatives such as the video conferencing learning sites, just like this one. We are pleased with the ongoing interest and attendance in this initiative. So welcome. We're happy to have you all here and hope you enjoy this presentation. I want to now introduce our presenters. The first of the two is Dr. Jacqueline PAE. Dr. PAE is a registered psychologist specializing in neuropsychological assessment. She has been a member of the Glen Rose Hospital's FASD diagnostic team and has taught psychology at several post-secondary institutions. She is currently an assistant professor at the University of Alberta, where she has her combined passions for teaching, clinical practice, and for research. The other person I want to welcome is Dr. Carmen Rasmussen, who has her PhD in developmental psychology from the University of Alberta, where she has focused her research on neurobehavioral development in children with FASD. So I will let you ladies take it over, and thank you very much.
Good morning, everyone. So today we're going to talk a little bit about FASD and mental health. If you look in your handouts, and maybe behind me shortly, we'll just kind of go over some of the goals for the session. Oh, thank you. Perfect. There we go. That's my organization right there. Otherwise, I'll be all over the place. What we want to start to do today is we just want to do a brief introduction and overview to mental health and FASD. We're not here to talk about what is FASD and what is mental health, but we want to make sure we're all on the same page for starting out. Then we want to talk a little bit about some of the research that's been done into mental health issues with FASD populations. And we're going to look at, and Carmen's going to talk about sort of the breadth of research that's been done in that area. We're then going to talk about some specific projects that have been done in Edmonton with regards to mental health and some of the programs that have been present in Edmonton and that this research has been conducted through. And then we're going to talk a bit about just some mental health intervention considerations. And what I'm going to be talking about today is we're going to look at things from a more systemic level. We're not going to talk as specific about individual treatments, but rather things that we need to do in a more general system-wide approach. Although that being said, I will probably also still say a few things about specific kind of treatment considerations. And then we're going to have lots of time, I think, for questions at the end of our session here today. So lots of time, so feel free to write down your questions as you go, because we will definitely get to them. Oh, and I'll go to the next one. So I wanted to start by talking about mental health, mental illness. When we're talking about mental illness or mental health or mental disorders or any of these kind of terms, what we're referring to or the way I like to kind of conceptualize it, is a continuum. Meaning we have sort of mental illness maybe on one end of the continuum, mental health over here. And the reason I like thinking about continuum is it helps us to focus not just on illness or problems, but also on strengths, because we're trying to work somebody towards greater health. And that's a continuum. It's not like we have to flip something. And that way we can take steps, and there are increments, and there's a process there. So when we talk, we're talking a bit about a continuum. And today, as we talk, I'm going to talk as much about illness and problems as about protective factors and strengths and things that we can work on, because I think that's a really big component, is not just talking about the problems, but where we're going to go. Thinking about mental illness, a lot of times we categorize it or we conceptualize it in terms of diagnoses. All I'm going to do, I'm not going to talk about all the diagnoses, or we're going to be here all day and into tomorrow. All I want to do is provide a bit of an overview of some of the domains that we look at. So for example, there are mood disorders, and the mood disorders include things like depression and bipolar. Bipolar meaning that we've got manic episodes. That's sort of a family, there's a larger family, but mood disorders. Then we may deal with anxiety disorders. Anxiety disorders include things like generalized anxiety, post-traumatic stress, panic attacks, specific phobias, which are like specific fears of things. So there's a broad range of things that can exist under anxiety disorders. Mental illness can also include externalizing disorders, acting out, behavior disorders. That's where we find diagnoses like oppositional defiant disorder, conduct disorder, even attention deficit hyperactivity disorder generally is categorized under that umbrella. When we talk about mental health or mental illness, we can also be talking about substance abuse or substance dependence. Sleep disorders is another one that we don't always think about when we talk about it, but it is sort of under that broad umbrella of good mental health. Reactive attachment disorder is another one that we hear a lot more of these days as well. It's certainly something that's got a lot more attention. So those are some of the broad categories of diagnosis. See, I went through those very quickly. I know I did, but my goal was not to kind of teach about these diagnoses, but just sort of to give us a conceptual framework for the discussion we're going to have today as we bring mental health and FASD together and think about the unique considerations. But why do we diagnose? What is the point of having a diagnosis is anyway? There's two key things. First of all, having a diagnosis sort of gives us a clinical understanding, a language. So when I say, here's an individual that's depressed, or I use the term depression, clinicians, researchers, people will kind of know what I'm talking about. They'll have a sense of what I'm talking about. So as much as anything, it's just a common understanding. It's to make sure people are on the same page. Another reason is to determine treatment. So when we think about treatment, we say, well, what's going on? Well, it's depression. All right, we need treatment for depression. And then research around depression has helped inform us as to what that treatment might look like. So having a diagnostic label helps us to define what might be going on and best understand what kind of treatment approach we want to use, and how, to look at how research can inform that treatment. So once we have a diagnosis, once we have something that we all agree upon, we have something that we can act on. We have something that we can research. We have something that we can evaluate. Okay, so those are some of the reasons why we even look at diagnosis. It's not about just pigeonholing people. It's not about narrowing. It's more about communication. And that takes us to my last point here at this point in time. We usually make diagnoses using our Diagnostic and Statistical Manual. It's called DSM. And that's sort of a categorization of mental health, mental illness. And it's basically a symptomatic guide and says depression may consist of all of these things, and it lists the components of depression, and it guides us in our diagnostic practice. And it helps to keep the diagnoses, generally similar. That being said, it's really important to remember that when we talk about mental health, there can be a lot of variation. And so we are not classifying individuals here, because two individuals, I keep picking on depression, so I'll keep doing that, two individuals with depression can look very, very different. So just because we say an individual is depressed doesn't mean we're going to fully understand everything there is to know about that individual. which really applies when we start talking about the FASD population. When we use these, they give us some information. A diagnosis gives us some information about some of the needs of an individual, but we haven't classified that individual. It's not a stopping point, it's a starting point. And so I think that's a really important spot, a framework for us to have when we think about mental health. And now we're going to switch over and we're going to start talking a little bit about FASD and then bringing the two together. So I'm going to talk a little bit about clinical implications here. I'm going to expand on perhaps a couple of the things that Carmen mentioned, although maybe not everything. I'm going to expand on everything she kept saying. I'm like, oh, wow, I don't know if I'm covering that. But that's okay because we're going to have lots of time, as we've already said, for questions at the end. So I'm happy to address anything that we need to go into in more detail at the end. Before I jump into clinical implications, though, I just want to talk a little bit about some caution when we interpret the research. And Carmen referred to some of these things as she was talking, but I want to be specific. Research is really important because it informs us as to the state of what things are at. Research tells us that, this is something we need to be thinking about, because when we're looking at the kinds of numbers that Carmen just talked about, this gets our attention and tells us this is a very relevant and important issue. That being said, we need to understand a little bit about research as well, and that it comes with limitations too, and we need to be critical consumers of that. First of all, a sample is just a sample. When we talk about samples, and a few times Carmen said, this is just 2 people, or this is just a certain number of people, we need to be really aware of how many people we're dealing with, how many people are in that sample. It's not necessarily an entire population. It's just a piece of that population. And knowing it's a piece of that population, we have to remember to ask questions about how we get that piece of the population. So, for example, the studies that we talked about are usually clinically referred samples, or they're people who are already needing some kind of help. What that means is the populations that we're studying are populations where there have been identified problems. That's why they've come onto our radar. That's why they're at a diagnostic clinic. That's why they're in a program for support. What we don't always know is how many people are out there functioning fine, doing well. Now, some of the studies that Carmen talked about are nice longitudinal studies, and some of the work that Streisguth has done, they've actually looked at a whole wide swath of population, so it hasn't always been clinically referred. But it is a question we need to be asking and be aware of, partly because it's important to know who are the kids, who are the adults that we're not seeing, because what's going on for them that is successful. That might inform our protective factors. So sometimes when we have clinically referred, we see a certain section of the population. It may not give us the whole issue. It may not reveal to us all aspects of what's going on. Other things we need to think about, and this kind of touches into what Carmen was talking about with some of this research when we talk about risk factors and protective factors. Thinking about risk factors and protective factors, and I'm going to talk a bit more about them too, but in general, we need to ask a lot of questions about what else could explain what we're seeing. How can we best understand what this research is telling us? What kind of supports were in place? What risks were there? What protective factors were there in a given study? So clinically, I'm going to talk in a minute about the fact we have to think about this clinically. But even when we review research, we have to ask ourselves, what defined this research population, so that I know how to take this very important research information and translate it into my clinical practice. So if I understand what the protective factors, what the risk factors, what all this information, this relevant information that sits with this research study is, then I also have more knowledge about what kind of questions I need to ask in my clinical practice. I need to know what protective factors are, because I know that if there's abuse or if there's violence, that's a huge risk factor based on this research. So that's part of the way, part of the questions we need to be asking. Bottom line, with research, as with anything else we do in practice or anything, we need to be critical thinkers. We need to evaluate the research we're seeing. And another thing that we did today, and that Carmen did in reviewing this, and I think is really important, is we talked about a lot of different studies from a lot of different geographical regions. We talked a bit about Canadian studies, American studies, German studies. The idea being is one of the things we do in research is we duplicate. And we're not just being redundant, and we're not just being lazy and doing the same thing over and over again. What we know is if we do things over and over again in different places with different groups and we keep finding the same results, it gives us strength. It tells us this wasn't just a fluke. This wasn't just a strange population that just so happened to be referred to me. This is what the pattern is. And the stronger that pattern gets, the more confidence we can have. So when we see the kind of pattern that we're seeing with mental health that is as strong as it is across the regions that it is, we can say with a lot more confidence, mental health is something we need to be stopping and looking at with this population. We need to be saying, what are we doing to respond to this need? Because it's been well established in this research. And we can have confidence in saying that. And that's a critical conclusion that we can come to with thoughtfulness and in review of the research like you've gotten today. So now I'm going to talk about thinking about services. And we're going to kind of take some of this research knowledge, which is really important and gives us our solid foundation, and we're going to interpret some of the clinical aspects of it and what we need to take into practice and service delivery and the way we structure systems to respond to this really apparent need. We'll just jump right in. So first of all, as Carmen talked, a lot of things that we heard about in the studies is there was talk about risk factors or protective factors, things that make it more likely that there'll be a problem or less likely. And I want to talk a little bit about that. And we're going to start with risk factors, and then we'll talk a bit about protective factors next. When we say risk factors, and here what I've said is I've put it down as etiology, which is sort of cause, and risk factors. And those two kind of go together. When we talk about etiology, we're saying what's causing the problem. When we talk about risk factors, we could say what puts somebody at risk for developing a problem, or what puts somebody at risk for having a bigger problem. So they're slightly different things, but they go together well. There's a few things that are interesting to consider. One is genetics. Something we know about mental health disorders is that there is often a genetic link. That means if your mom or your dad or your aunt or your uncle had problems with depression, you may be more likely to have problems with depression. This might be something that we're dealing with the FASD population. If we're thinking about a mom who is drinking alcohol during pregnancy, we know that substance abuse and depression go together. There's a lot of research that talks about depression and self-medication through alcohol use, or depression that's linked to abuse, and therefore we're seeing some substance abuse. There's a lot of patterns that link these things. So if we've got moms who are drinking alcohol in pregnancy, some proportion of those mothers may be dealing with mental health issues. They may be dealing with depression. They may have some of these things that are contributing to why they're drinking. So what that tells us is just even knowing that piece and not knowing any more about the families and not knowing any more background is that we may be dealing with a population that even genetically is at higher risk for developing mental health issues. So that's a genetic piece. And that's important to know because when we think about, okay, what's at the root of this? If we say genetics is at the root of it, or at least in part at the root of it, then all children, all adults, regardless of environment, regardless of situation, may be at higher risk for developing mental health. So it's not just our children who have more risk factors, but all children with alcohol exposure may be at greater risk of developing a mental health problem because of that genetic link. Environmental stressors. Carmen talked a lot about this, and she talked about the children. When we get multiple moves, there's greater stress. Exposure to violence, trauma, significant factors. Specific traumas are big risk factors. We talked about the elevated incidence of post-traumatic stress disorder. That is directly linked to that exposure to specific trauma, both for children and adults. These are risk factors. So we may have somebody who is genetically predisposed, and then we put them in an environment where we pop them through lots of different homes, possibly expose them to violence, to trauma, and no wonder we're seeing 6-year-olds with mental health issues. No wonder. I mean, it's amazing that many of them are functioning as well as they are, which I'm going to talk about too. but these are really significant issues. Carmen mentioned reactive attachment disorder, and that's something that we do see a lot of. And that does relate to a lot of these environmental stressors and traumas, in that we do get kids who, because of all these multiple moves, especially in their first couple of years of life, when they're young, 1 year, 2 years, if they're bopping around, we get kids who don't learn how to attach, and they don't learn to have that safety in attachment that we really need. Safety in attachment, or secure attachment with an adult, gives us the ability to sort of negotiate our world and figure out how to interact with others. If we can't connect with an adult and we don't sort of have that safe place from where to explore, then we're at risk for a lot of other problems. And that's sort of at the root of reactive attachment disorder, is that lack of a secure base, a lack of a secure attachment. Transience, homelessness, marginalization, all of these kinds of things which link into what are secondary disabilities are other risk factors that we see either in adolescence or adulthood. I'll say typically we don't see as many of these in children, but we do see them in adolescence, absolutely, and we do see them in adulthood. And so here again is where we see elevated risk. So we may be dealing with a child who has not developed a mental health disorder, but then by 13, they're out on their own. They're homeless, they're living out there. All of a sudden, the risk for mental health skyrockets. Transition periods in life. Transition periods can be a huge risk for individuals with FASD. Transition meaning transition between homes, transition being transitions between schools or grades, like grade 6 to grade 7, huge transition depending on your school system or where your school systems break. Transitions into high school can be big. Transition out of high school, big. All of these areas are risk pieces as well that can elevate that risk for development of mental health. Anytime we add stress to a system, anytime we add stress or add pressure to a human system, a person, we put them at greater risk because we may be kind of tapping their threshold. You know, we all have a certain amount of stress that we can take in life. We all have sort of our stress cup, or things that we can talk about. And when that stress cup starts to overflow is when we start to see, mental health problems emerge, or we could see mental health problems emerge. So the more we add in terms of stress, which could be any of these kinds of things, the more at risk an individual becomes. And it could be that, say, genetically, an individual may have a smaller cup. Also with FASD, and I'm going to talk about some of the specific, brain pieces very briefly with FASD, but we also may be looking at a brain injury pattern that reduces the size of this cup. So whether it is the unique nature of their specific brain injury that renders them more vulnerable to mental health, or their specific brain injury reduces their coping strategies. Their ability to cope is less because of the nature of the brain injury they have because of their prenatal alcohol exposure. So those pieces can also contribute to risk and can elevate risk based on a given individual. So that's risk factors, or a few of them anyway. Let's talk about protective factors. Let's go on the other side, because if you remember at the beginning I talked about a continuum, and I said I really like to think about mental health along a continuum. See, I'm talking about cups, I'm talking about continuums, I don't know, I have to keep the metaphor the same eventually. But if we're talking about a continuum and we want somebody to move towards the healthy end, one of the things that we really be aware of is not just where are the problems and where are the risks. So we want to reduce risk, that's good. But we also want to be aware of the strengths. Because if we can increase strengths, if we can do two things, reduce risks while increasing strengths, we've just increased our ability to support somebody and to help somebody. So we want both of these pieces to be on our radar. Again, genetics. I put genetics up there again because, genetics are part of what makes us who we are. And it's sometimes important to have a little bit of knowledge about somebody's history to identify what some of their strengths are. The strengths that a parent may have, the strengths that a mother may come to the table with. So yes, mom may have some difficulties, but mom may also have some incredible strengths. So if you're dealing with a child who's been prenatally alcohol exposed, it may also be valuable to have information about the strengths of mom, because there are strengths too, and I think that we recognize both pieces, it's going to be helpful, or dad or other family members. in terms of their ability to cope and what has worked for them. Individual strengths, survival skills, these kinds of things, what's getting people through. Sometimes I'll work with kids who have been quite marginalized and have lived on the streets, and they've had it really rough, and they've developed some mental health problems, often around substance abuse, often around depression. I see a lot of anxiety disorders in adolescents. But you know what? I sit down with them and I say, tell me about your last week. And they're talking about the car they slept in, and then they're talking about where they managed to get food, and they usually have these systems in place. Well, I go to this person, and then from this person I go here, and I go here, and by the time they're done talking, I'm usually quite lost. I go, oh my goodness, how do you manage all these steps along the way? What incredible survival instincts there. Like, that's amazing. So you've been living on the street for a week. You're still alive. And Edmonton, for those who are not in the Edmonton area, we're not the warmest city in the world. So sometimes, depending on the climate, a week on the street is pretty incredible. I don't think I could do it. I mean, that's scary, and yet they are able to do this, and they're still kind of feeding themselves. They're finding somewhere to sleep. What can we learn about the things that they have done to keep alive and to make it, that tells us about that survival skill, that's something they're drawing on in order to come up with some kind of system to make it through, even if it's sort of knowing who to talk to or when to talk to them. If you can figure that out on the street, maybe we can translate that skill to something a little bit healthier for you and just take what you're already doing. Support systems. Again, Carmen mentioned support systems as a protective factor and talked about support systems as those with support systems are more likely to have success. Those who are in a stable home, those who have stable caregivers who sort of stick with them over the years, they're more likely to have success. And that's a positive piece. Stability, that's what I just said. So looking for the protective factors is just as important as looking at the risk factors and the problems. So I guess if I was to put it in a clinical nutshell, I would say we really want to open our minds to both pieces and ask a lot of questions about both pieces with every individual that we work with. All right. In addition to asking these questions about risk factors and protective factors, I think one of the really important pieces that is specific to this FASD population that we work with is trying to get information regarding their individual functioning, what is going on in terms of their profile and their underlying brain function. Two individuals with FASD, and I'm sure a lot of you guys know this, can look incredibly different. And they can come with very different skill sets, not just based on life experience and all these other things I've been talking about, but because of the unique nature of their brain dysfunction. As we know, alcohol affects the developing brain, and depending on a lot of different factors, timing, dose, just being two of them, the brain damage can look very different. For some individuals, memory is really significantly impacted. We need to know that. If we're going to work with a client, we need to know what their memory functioning is like. Because if I'm asking them to remember something, and they've walked out my door and they've forgotten it the minute they get to the other side of that door, I've not done them any good. So memory, I need to know. Problem solving. What's their ability to solve problems? Are they rigid thinkers? Do they get stuck in one way of doing things? Or can they generate a couple other solutions? Can they be a little bit more flexible? If they can't, and if that's a brain level issue, if at a brain level they are unable to come up with more than one solution to a problem, then if I sit down and say, let's do some problem solving and try to generate solutions, I'm putting them in a place where they just can't succeed. They're going to have difficulty. I need to understand that they may be a more rigid thinker, and I need to work with that, and I need to figure out how to work with that. But if I don't understand that is a need of this individual, then how do I know? Level of functioning, cognition. How much are they going to understand? At what level developmentally are they functioning at? I need to respect that, and I need to be aware. Language functioning is another huge one. What level is their language at? What point am I speaking at a level that makes sense to them? Because I don't want to talk to them in little words and really slow if they're looking at me going, I'm beyond that, thank you. At the same time, I don't want to be speaking at a level that somebody doesn't understand. And I need to be able to tailor my response to that individual. And the thing with individuals with FASD, and I'm sure those of you who have worked with this population know, is appearances can be deceptive. Appearances can be deceptive. So for example, cognition does not always match function. So I've worked with individuals who say, oh, I got information about their brain. Their IQ, it's average. IQ is average, so they're fine, they understand what's going on. And I'm like, oh, I wish that were true. You know what? IQ does not always translate into function. Having it and using it are two different things. We need to know that. And we not only need to know what they have, but we also have to have an idea of what they can use. What is their adaptive function? So if we want to work with an individual, we need to understand these pieces about them. We need to understand that just because they talk well and they come up to me and they're blah, 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 blah. From my clients, they sit down and they say the most amazing things. And they use language that I'm impressed with. They'll talk about this therapeutic approach that they've been using and and I'm like, wow, that's great. You're doing Gestalt work and you can tell me that you're doing something in a Gestalt approach. Wow. So then I say, so what's Gestalt mean? Oh, well, oftentimes our clients can use language that they don't even fully understand, but they learn how to sort of say the right things to us. And so we need to be tuned in to their needs, not because we want to catch them in it. It's not about that. We're not looking to embarrass them. We're not looking to catch them in their lie. This is not what they're doing. They're just trying to please us a lot of the times. I find a lot of my clients really want to deliver. They want to do well. They're like the rest of us. They like praise. They like to do well. We all like to succeed in life. That's a normal thing. And so they've learned to some degree that if I say the right things to the right people, then I have had some success. And so we need to find other sort of measures, and I'm getting ahead of myself, which is not all that unusual. But anyway, so what I'm starting to talk about here is sort of our strategies and the way we think about delivery. So now that we've considered the unique brain that we're dealing with FASD, we've considered risk and protective factors when we're talking about mental health. We've kind of got all these pieces floating around, and there are a lot of pieces, and it's a complex picture, but they're all kind of floating around. What kind of system level things do we need to be thinking about? What kind of service delivery things do we need to be thinking about? One thing is, we really need to think about how we define success and failure, I think. And I think it's very different for different programs and different people. So this is more of a general statement. And some people I've seen, and in fact, almost everything I'm going to say here today, I'm saying because I've learned it from somebody who's practicing it. So I am not inventing new things for you today. I'm sharing with you things that have been shared with me and I've experienced that have been really good with clients. And so it's just sort of to have us all on a common page. But looking at success and treatment. So, for example, treatment decisions based on attendance or maintaining. This is something I've run into a few times where I have clients where they get into a program and the program says you need to show up. And if you don't show up, it tells me you're not committed and you're not interested and you're out of the program. And so your attendance is what I measure your success or failure based on, or at least in part. Well, with the FASD population, again, we all know that this is really, really hard for this group. Let's go back to memory. Right? They get up in the morning and they go, okay, what day is it again? Is it Monday or is it Tuesday? They may not even know. I don't remember. What was yesterday? Okay, I might be on the wrong day all day. Was that appointment yesterday or today? If they even remember there was an appointment or there was a meeting to get to. These kinds of things can be easily confused. Time sense of time can be very confused in individuals with FASD. For some of them, depending on their specific unique brain. And so if their sense of time is confused, they may say, all right, I've got half an hour before I go to that appointment, I'm going to go and do this first. And most of us, we can go out and we can do something, we have a general idea of what half an hour feels like. If you don't, 3 hours go by and you go, oh no, I just went for half an hour. I've had clients where they say, I'm just going to go have a quick smoke. And I'm like, okay, good, go have a smoke, good for you. Come back right away afterwards. And they'll, yeah, I'll just be about 5 minutes, 10 minutes. Okay, an hour later, they come back. And I'm like, where have you been? I thought I lost you. And they're like, I was just gone 10 minutes. And I'm like, no, you were gone an hour. You were gone an hour. Oh, wow, I'm really, and they're very sorry and they're apologetic. But that sense of time wasn't there. So again, when we think about attendance as an issue of, are you succeeding, are you failing, we're doing that with a population that is already set up for failure based on some of the brain difficulties they have. And that's a real challenge for us. And so looking at how can we support attendance is a much better thing than we need to kick you out of the program because you're not attending. Instead, we need to say attendance is an issue. How can we support that? What can we do differently? How can we change? Because we can't expect you to fit to our system. We need to fit to your needs. It's a different way of thinking. I don't want to force you to fit you're into my square hole here. We need to adapt to meet your needs. Again, be aware of the appearance of success, and this takes us back to my earlier comment about sometimes individuals with FASD will present and sound much better than they are. And so they may be going through treatment or therapy, and they could sound great, and wow, they've got it all, and I'm listening to them, I'm thinking, yeah, we're done. You've got this all figured out. You're great. And yet, they don't understand a lot of what they're saying. They've just learned to kind of give me back the language. They're not really able to apply these things day to day. It may or may not have meaning for them. So I may be working with somebody to help with their substance abuse, and they're telling me all the right things, and these are my triggers, and these are my this, and they may have it all figured out, but can they actually act on that when they're out in the community? And they'll say, yeah, I know that when I feel this way, I don't do this, and when I feel this way, I don't do this. When I'm home with my kids, I definitely don't do this. You've been successful, you passed, we give you the stamp of approval. A week later, Children's Services goes to their home and says they're doing exactly the same thing. They're drinking around their kids again, or something is happening. Just use that as an example. And they're going, and they've been through treatment, so therefore, they're truly choosing to do this. And then all of a sudden we get into this funny little blame game, and we go, they're just rejecting everything we did. And we're not saying, wait a minute, how do we really know that what we did in terms of treatment, was it all effective? How do we know they were able to translate that into action? At what point do we stop and see, do you have the ability to translate that? What's happening for you day to day? What meaning does that really have before we start to evaluate whether or not you've been successful? And so I think really rethinking what we mean when we say success and how we evaluate whether or not somebody has been successful. And I think some of that is going to be answered as we continue to link research with therapeutic approaches and clinical approaches, is where we start to say, okay, how are these things working? And while Carmen reviewed a lot of the research that's out there in terms of mental health and FASD, as you saw, a lot of it is descriptive. A lot of it is just telling us that this is a huge issue. There is not yet really anything out there that's saying, so what do we do about it? What interventions do work? How do we know if we're having success? How do we know if it's working? That's not out there yet. We don't know. And so there are some clinicians in some places where they have a great idea and they've learned to really work with clients. And that's here and there. But how do we generalize that? How do we translate that knowledge? That's where we want to bring clinical work and research together and really start, because that'll help us to understand what's going to work and how we can redefine success and how we can make it fit for these unique clients. Another issue with this and that we need to think about is communication between systems. I'm seeing eye rolls in front of me here, so I guess we've hit on something. I know for myself, a great frustration is when I'm working with a client and I'm kind of listening to their story and I'm hearing about their life. And they tell me about how they went into one service provider, and they work with that service provider and they try so hard. It kind of makes me think of a hamster on a wheel sometimes. That's kind of the picture I get in my head. And they work and they work and they work and they don't show up for stuff, and they kind of comply and then they don't, and over a course of their engagement with that service provider often burn out the person they're working with, who's trying so hard but is getting discouraged and not sure how to handle it. So finally this person is kind of, you're out of here, we can't provide support. So that person's back at ground level again, and now what do? We go to the next system. We access that service. And is there any communication between these two? So this one can say to this one, hey, watch out for this, or here's a way to work, or this is something no, we don't do that. We wait until that system gets burned out, then we leave it, and we go to the next system, burn it out, and we've got this great systematic burnout going on, I think. Or that's what I would like to suggest. So what does better communication look like? What does better communication look like in a time when we have to be so conscious about confidentiality and FOIP we've got here, Protection of Privacy Acts, those kinds of things? Well, that's a huge challenge. And I don't have the answers. I wish I was here to say these are the answers, this is what we all need to do. What I know is we need to find ways to communicate better. We need to break down the isolation between these systems. This has to happen. I've seen it happen on case-by-case level. I've seen it happen with a few key people in different systems who are incredibly innovative and have energy that is amazing and have just leapt over hurdles to bring systems together. So I know it can be done, and I know that when it is done, I see amazing things happen for clients. When we team up, I see things happen because we can address a lot of different aspects of their lives. But we need to think about how to do this across our systems, not just case by case. Because if we can do it across our systems and we can put something in place, maybe we're going to see less burnout. Maybe we're going to see less need to generate this unbelievable amount of energy client by client, and rather we can have a system of support. When I'm talking about systems, they can be anything. I mean, we can be talking education system is one big system that is engaged with kids, right? And even young adults. Sometimes we're dealing with adult educational systems. Justice systems, huge system for this population. Carmen talked about statistics in terms of secondary disabilities and incarceration. That's another system we need. Mental health systems, health systems like hospitals. Boy, a lot of hospital visits. This is another population. I often will request hospital records. I like to get records and stuff when I work with clients to try to get information from these different systems. The amount of hospital records, just usually emergency room admissions, tons of these things. I'm like, wow. And different hospitals, not the same hospital, so there's no continuity there either. And so there's no connection and no bringing together. What can we do to link these systems? What can we do? And that needs to happen on a bit of a system level, I think. We need to evaluate that. And that's sort of a, like I said, not an answer, but I think it's a really strong statement of something I think we need to challenge ourselves to say, enough of saying, well, we can't do it because the system doesn't work that way. Enough. Time to say, what do we do to change the way we work? Because we need to do that. We need to reevaluate these things. When we change the way we work, when we integrate our systems more effectively, when we enhance communication, another thing I think that is going to enable us to do is be more preventative. Be more preventative. Early on in our presentation, Carmen talked about the difference between primary and secondary disabilities. To some degree, some aspects of mental health are secondary disabilities, meaning preventable. Meaning if we can have more stability, reduce abuse, reduce trauma, and I think even abuse, when we look at somebody who has to access different systems, I think we're re-traumatizing. I think we're re-abusing people in a system that forces people to go, and burn out and continually fail and be rejected. I think we're re-abusing. So I think we are contributing to the amount of secondary disabilities. So just by being better communicators, I think we're being preventative right there, because we're going to make the system more accessible to people. It's going to be more sustainable, the support systems that we create. But preventive is also saying we don't want to just be focused, and this comes back to my continuum, on the failure, on the problems, on the disability. We really want to be looking at people's strengths. We really want to look at abilities to foster strength and development in an individual. I don't care that you are FASD. You still have strengths. You still have abilities, and if we can capitalize on that, if we can find your unique abilities and build on that, the potential for success is better. All right, we've got a stronger individual. We're moving along that continuum towards good health because we are strengthening you. Right? We're building those muscles. I guess we're repeating one. I guess I really wanted to emphasize preventative approaches here, so we're emphasizing it. I'm adding in care for the caregiver as well. And I think that comes back to the systems and burning people out. But I always like to add this in because I do find that a lot of caregivers I work with, speaking of burnout, These are people who really, really can struggle. And I think that we often are looking at the system to support an individual, but I think that individual sometimes comes with their own little microsystem too. And we need to be aware of their existing microsystem that they come with. I love systems. I'm into system talk these days, I think. So we have big systems and we have little systems, but I do believe a lot of these individuals come with little microsystems already. That may be a parent or a caregiver, but it also may be an advocate or a mentor. Carmen talked about the step-by-step program that comes with mentors. Their mentor may be part of their microsystem, and if we have knowledge of who that person is and we can respond to their microsystem, we're also going to strengthen that system as well and connect them. But just to draw our attention. So, still sort of thinking system, and like I said, I don't want to get too much into detailed clinical counseling approaches because I know you guys, there's going to be other mental health presentations coming up, and that's going to be the focus of those. But what I do want to say about the way we do is draw our attention to the fact that traditional counseling options may or may not always work. So things that work with other populations sometimes will and sometimes will not work. We need to think about it. I find in particular psychotherapy or insight-based therapies can be a real challenge for this population, partly because they're often language-based and partly because they often require a level of insight that the nature of an individual's brain injury may make it hard for them to access. So being really conscientious about the approaches we use. Well, I counsel people for depression, and so when I work with depression, this is the approach I use. Okay, but this individual has FASD. How does that approach need to change? How much do we need to flex? Again, it's about us flexing to meet the needs of our client, not asking our client to change to fit within what we're used to delivering. So, for example, cognitive behavioral therapy is well documented for working with depression. Lots of research evidence saying this can be a really good approach. Will it work with an individual with FASD? Maybe. Sometimes it can. Sometimes it can produce the structure, but a lot of times that cognitive level that requires an awareness of triggers and anticipating things and seeing what's coming isn't always easy. Sort of understanding that there's an antecedent, there's a before my behavior, that awareness isn't always there. And if it's not there for a given individual, then we may need to adapt that. We may need to say, well, it's not going to work in this form, but maybe we can use a more traditional behavior model and then use other supports around it to help create the awareness pieces. Or we can look at external structures to inform. Developmentally appropriate interventions. This comes back to, again, knowing your client, knowing the unique strengths and difficulties for a specific client. That can help inform what we want to do and making sure it's developmentally appropriate. Sometimes even older kids, I'll recommend play therapy. And I'll say, yes, they're adolescent. Yes, that's not a population we would always want to look at play therapy for. But you know what? I've seen some adolescents who have done amazing things in play therapy for FASD. Because they don't have the language, they don't even have the ability to kind of put their thoughts together in a way that makes sense. But when they're playing, oh my goodness, the things that come out. Wow. And so then you can model alternative play. And there can be some interesting things that can come out of that, even with an adolescent or, older individual. There's some interesting things around drama, acting things out even physically. Phototherapy, doing pictures and talking about pictures and visual. There's some very interesting things that are out there nowadays that would allow us to look at these alternatives. Physical stress reducing approaches. Sometimes very physical approaches work. When we think, I keep picking on depression today, so I'm just going to keep it up. But let's talk about depression again. When we think about depression, we know that it has sort of a cognitive, a thinking piece. We know it has an affective piece, an emotional piece. And we know it has a physical piece, a body piece. What if we deal with that body piece? What if we say cognitive is a little hard to tap into for reasons? Affective, well, we're not sure what approach might work, but let's start with physical. And let's do some body things, some body exercises, some body work. There's a lot of research out now talking about trauma and work that can be done with kids around physical release. Why not do that with adults? There are approaches for adults that do talk about using your body and feeling in your body and getting to know your body better. Sometimes even simple stress release, learning to recognize tension in your bodies, knowing how to breathe differently can help. If somebody's got an anxiety disorder and we can get them to learn how to breathe in a way that calms them down, that's a long way. That can make the difference between an outburst and not an outburst. If they can start the ability to kind of soothe themselves and bring themselves down a little bit. And so looking at those kind of physical approaches may be another way to go as well. And you're going to get all these kind of details. All I'm saying is when we're working within our systems to have sort of a big frame to work from, we don't need to throw the baby out with the bathwater, so to speak. What we need to do is look at our existing toolbox, look at the tools we already have and say, how can we work with these tools in a way that makes sense for this population? How can we adapt our tools that we already have to work best with this population? We don't need to create new ones all the time. Sometimes we just need to figure out how to use our ones we have and just be prepared to use them a little differently. Some reminders, things I've kind of alluded to already. Beware of stigma and self-fulfilling prophecies. Oh man, yes, an individual may have FASD. That does not mean they're on a trajectory for failure. That does not mean, in my opinion, that things are over. Doesn't mean that there are some risks. Oh yes. Doesn't mean that we have to do something to step in. Yes, we know mental health problems are around 90% for adults. That's huge. That should have our eyes bugging out and us going, oh my goodness, what can we do? But is that a have-to-be scenario? No. Can we do something differently? Yes, I believe we can. And I think that if we say FASD, oh man, this is going to be trouble. Oh, this is going to be a problem. Okay, who likes walking into that? How many of us are prepared to commit ourselves to something if we walk in the room and they go, oh, you're that. Oh, well, probably not going to have success here. If we've already assumed failure before we started working with somebody, I mean, I don't need to tell you guys this. You guys, we know this. It's not going to work. So just kind of a caution is while we want to be fully aware of the risks and the challenges that come with this population, I'm not here to fool us, and I don't want to just be saying it's all sunshine and roses. But I also want us to remember that there are positives. This is a population with strengths, and we can see success. I really believe that. We need to move towards enhancing strengths, not just focusing on deficits, and remain hopeful. Because if we're hopeful, that will translate to our client. And if that's one thing that we can really foster in them, it is hope. And that will help them to move forward. Keeping our eyes on our goals when we're looking at a systems level. We need to have goals. We need to have things that we're shooting towards. And I think these are three that I identify, and they're not exclusive, and it's not all of them necessarily. But I think we can reasonably say we want to see a reduction in secondary disabilities. We want to see a reduction in things like incarceration. We want to see a reduction in suicide rates. We want to see a reduction in exposure to violence and trauma. We want to see some of these things coming down. We want to see a reduction in school dropouts. These are things that I think are really reasonable goals that we can set. And they're measurable goals so that when we're doing research, we can also evaluate our success in these things. Improvement in life functioning. Again, we not only want to see a reduction in problems, we want to see an increase. Carmen talked about one of the studies that talks about satisfaction and how happy these women are with FASD with their lives. And a lot of them are not. Quality of life is not reported as high. These women or men or individuals with FASD are not reporting a high quality of life, are not being seen as having it. What can we do to increase that quality of life? What can we do to improve that life functioning? What things can we do to change those pieces? And when we talk about life functioning and adaptive functioning, that can be anything from maintaining employment, maintaining housing, staying out of problems, maintaining, if you've got children, parenting supports, parenting care. Some of it can relate to being able to be involved in a few other things, having a social setting, having extracurricular activities, being involved in activities that you enjoy. Those can all be improvement in life functioning. Okay? Prevention of FASD, I think, is a huge goal, and I think we all share it. I think the more we can support individuals with FASD, the more we can reduce our secondary disabilities, including mental health, say depression, substance abuse, the more we're going to see prevention of FASD. This is where it starts. It starts with these systems, and I believe it really starts with these mental health pieces, because I think they're one of the biggest pieces that contributes to the perpetuation of FASD. And then we ask, are we achieving our goals? And so, like I said, part of what I want to do today is challenge us to think, challenge us to put our heads together, challenge us to research the ideas we have so that we can generalize and disseminate that information, share that information so that we can all act on it. And then always come back to, are we achieving our goals? Are we doing these things? In my mind, the future of interventions, as I like to say it, an integration of systems that build on strengths and support challenges. Sounds so nice in a single sentence, doesn't it? If only it weren't so hard to do. Empirical evaluation and support of strategies. Just because it feels good, just because it sounds good, doesn't mean it's working. We need to have evidence that the things we're doing is working, because that is how we're going to build, and that's how we're going to have more intervention. Long-term program planning looks at lifespan, not just the next 6 months or this budget or whatever. We need to stretch. So not only do we have to stretch across systems, we have to stretch across time and be able to provide long-term supports, look at the lifespan, and reduce the negative impacts of things like transitions and other stresses that come throughout that lifespan, and are prepared to respond to them.
So my name is Carmen Rasmussen, and I'm going to be talking about some of the research on mental health problems in children with FASD, and then Jackie will take over again for the second half to talk about some of the clinical implications. I'm not going to really go into much background on what FASD is. I'm assuming most people have a general understanding. Prenatal alcohol exposure produces a range of effects, including fetal alcohol syndrome and fetal alcohol effects, and those fall under the umbrella term FASD that we're using now. So the general kind of definition established by Chudley et al. Of FASD, it refers to individuals who may have physical, mental, behavior, and or learning disabilities as a result of maternal alcohol consumption. When we speak about FASD, we like to, especially in the research done by Anne Streiskath and colleagues in the United States, she tends to divide the type of disabilities into two different types of disabilities in these individuals. The first are primary disabilities, and those directly result from the brain damage of prenatal alcohol exposure. So they are evident in some form from birth, and because they're a direct result of the effect of alcohol on the brain. So things like difficulties with intelligence, memory, and attention. Now, of course, you can't always fully measure these things from birth, because it's very hard to measure memory in an infant and whatnot, but they are evident in some form from birth, and we do see difficulties in those early on. The second type of disability is secondary disabilities, and these result from the primary disabilities, which are a result of prenatal alcohol exposure and brain damage, and environmental interactions, and they are not evident from birth. So in theory, the secondary disabilities are preventable with a better understanding of appropriate interventions. Common secondary disabilities include, one is mental health problems, other ones are problems with school, trouble with the law, substance abuse, things like that. And I'm going to talk about research study on secondary disabilities. So most of what we're going to be talking today has more to do with the secondary disabilities and things that, in theory could be treated or prevented in these individuals. So now I'm going to take you through some of the previous research on mental health and FASD, because I think it's nice to learn about what has been done already, because there actually is quite a bit of research in this field conducted in the United States and in Canada. So I'm going to talk about studies looking at children and adults with FASD and looking at the mental health problems. We'll also talk about suicide and FASD, and then also an interesting new study that came out looking at very low levels of prenatal alcohol exposure and how those affect mental health. So Anne Streiskath, whose name is at the bottom there, conducted a very large longitudinal study starting in the early 70s, where she followed over 400 individuals who were exposed to alcohol and or had FASD, and she's been following them for over 30 years now. It's the largest ever longitudinal study conducted with individuals with FASD, and they've published hundreds of papers on these individuals, and we've learned a great deal from this study. She did one specific study focusing on these secondary disabilities in these individuals. So she measured common secondary disabilities among 415 individuals aged 6 to 51, all who had FASD or prenatal alcohol exposure. And what she found was very compelling. More than 90% of the sample had mental health problems, so that's obviously much, much higher than you'd expect in the general population, and obviously a very significant concern. And this is one of the first seminal papers to really document mental health problems in FASD. And they classified mental health problems as being one of these secondary disabilities, but other common ones included inappropriate sexual behaviors, disrupted school experience, trouble with the law, and alcohol and drug problems. And you can see how these other secondary disabilities could also probably further impact mental health problems and potentially worsen those as well. An interesting thing that they did in this study is they didn't just want to measure the problems in secondary disabilities, they also wanted to look at protective factors that protected against having these problems, these secondary disabilities and mental health problems. And they actually found among either 415 people, there were 5 main protective factors that protected against having these secondary disabilities. So one was living in a good quality home, and as we know, children with FASD are overrepresented in the foster care system, and there can be lack of stability in placements and whatnot. So, and also having few changes in living arrangements. So if they had a good quality home they were living in, and also a stable home where they weren't being moved from home to home to home, that was a very protective factor against these problems. Another was not being exposed to violence, either family violence or being abused themselves. And it turns out that exposure to violence turns out to be quite common among children with FASD, so the ones that don't have that tend to do better in terms of the secondary disabilities. Another protective factor was receiving services for developmental disabilities, so those that were actually, maybe had an aid in school or were in some sort of intervention program or that were receiving mental health counseling, things like that. Any sort of service that they were receiving served as a protective factor. And the last one was being diagnosed before the age of 6. So in general, the earlier the diagnosis, the better the outcomes in terms of these secondary disabilities. And this one's really important because it really highlights the need for early diagnosis, and if you can get involved early on, the changes that can be made in the child's life. So that's the first main study. It was published in 1996, but it was from data that had been collected since the 1970s following these individuals over time. Another study was conducted by O'Connor et al. In 2002, and they documented very high rates of psychiatric disorders among children with prenatal alcohol exposure. So in this study, they just had a group with prenatal alcohol exposure, and they didn't necessarily all have a diagnosis of FASD. And they found 87% met the criteria for a psychiatric disorder. This is a different sample than in Streisketh's study, so as you can see, 87% is very similar to the 90% that we saw in Streisketh's study. And of those psychiatric disorders, the most common were 61% met the criteria for a mood disorder, 35% for bipolar disorder, which Jackie talked a little bit about, and 26% for major depressive disorders. So these are all rates that are much, much higher than you'd expect in the general population, and obviously are very disconcerting for this population. And again, this was children, this wasn't adults, this was children with prenatal alcohol exposure. And when they looked at the youngest age within their study, even among the 6-year-olds, prenatal alcohol exposure was associated with depressive symptoms, particularly for the girls. So this goes to show that these mental health problems and psychiatric problems are starting very early on, and are, for the depressive symptoms may be worse for girls. Another study conducted by Walthall et al. They looked at children aged 6 to 12 who had prenatal alcohol exposure, and they also found much higher rates of psychopathology. And here they found very high rates of anxiety disorders, disruptive behaviors, and again, mood disorders. And this was in comparison to other children without prenatal alcohol exposure. Okay. I'm going to talk about another study conducted by O'Connor et al. This one was in 2006. And they thought that there are probably many, many children in inpatient psychiatric services and hospitals out there who have FASD or prenatal alcohol exposure but are not exposed or that are not diagnosed. So probably many of the children that people are seeing in psychiatric hospitals probably are exposed to alcohol, just it's not documented or it's not known or they haven't been diagnosed. So they actually did a study to investigate this. This was a really interesting study. What they did is they did a chart review of 130 children who admitted to a psychiatric inpatient service. And so they looked at these children. The children, they didn't come in thinking that the children didn't come in because they had FASD or anything like that. They came in for mental health problems. And they did a chart review to go back and look at to find out how many of these children were exposed to alcohol. And what they found was 30% had documented prenatal alcohol exposure. So that's very, very high. So 30% of the children in this inpatient service actually were exposed to alcohol. Now that's probably an underestimation because there's probably many, many children who, out of that sample, who were exposed to alcohol, but it maybe wasn't documented in their files because obtaining an accurate history of prenatal alcohol exposure is really difficult with an FASD. So 30% actually had documented prenatal alcohol exposure and probably many more had suspected, but there was no for sure evidence within the files. And of those 30%, 26% met the criteria for full fetal alcohol syndrome. So 26% went on to actually get diagnosed with fetal alcohol syndrome. And that's really important because none of them had the diagnosis prior to admission. Okay, so we're dealing with the high-risk sample here of children with psychiatric problems, and not knowing that, almost a quarter of those with prenatal alcohol exposure actually had a diagnosable problem, fetal alcohol syndrome, which could explain a lot of their mental health difficulties. So this is a really important study, and they went on to diagnose these individuals. They found that when they looked at those who had prenatal alcohol exposure and those who didn't, the ones who did have it were more likely to be referred for externalizing problems, so kind of more of the acting out and the behavioral problems, than those who didn't have prenatal alcohol exposure. So externalizing problems in this sample seemed to be particularly predictive of being exposed to alcohol. Another study by Fryer et al., they compared psychopathological conditions among children, 39 children with prenatal alcohol exposure and 30 children without prenatal alcohol exposure. And this was actually based on caregiver interview. They interviewed the caregivers and they had the caregivers fill out various rating scales measuring these different mental health problems. And they found group differences in that the prenatal alcohol exposure group had higher rates than the group without prenatal alcohol exposure on ADHD, on depressive disorders, oppositional defiant disorder, and conduct disorder. So Jackie's talked about a few of these already. ADHD, I think this is the first time this has come up so far in the presentation. And also on specific phobias. So they found a wide variety of differences between the two groups. And again, significantly more children in the prenatal alcohol exposure group were showing these mental health problems. And it turned out that actually ADHD was the largest group difference. So our ADHD was the most common mental health problem among the sample of children with prenatal alcohol exposure. And it was the mental health problem that was most likely to differentiate between those with and without prenatal alcohol exposure. So they actually concluded that fetal alcohol exposure should be considered as a possible factor in the pathogenesis of childhood psychiatric disorders. So that's a pretty bold statement to actually say that, this, can be considered a causal factor in some of these psychiatric disorders. And I think that when Jackie talks about the clinical implications, she'll talk a lot more about that. So everything I've been talking about so far, these studies have come out of the United States, out of various groups in the States who have been very productive in studying FASD. We've also had a very productive group of researchers German researchers who have been also conducting at the same time longitudinal studies on German children who are exposed to alcohol. So these studies are mainly led by Steinhausen and Spohr, and they have many publications over the years. The data I'm presenting today is coming from 4 of them, but Spohr, Steinhausen, and their colleagues have published many, many papers on FASD among German children. And it's really interesting because we can actually look at the comparisons across different countries and actually see similar results, which I think is very compelling, which really goes to show that we're actually seeing some similar things across different areas. So in their German longitudinal study, again, they found very high rates of psychopathology, high rates of hyperkinetic problems, emotional disorders, conduct disorders, sleep disorders, which hasn't kind of come up in the previous studies, mainly because I don't think they actually measured it, but there actually is a line of research coming out now showing that sleep problems are quite common among children with FASD. They also saw just abnormal habits among the children and stereotypical behavior. So these were the common psychopathology that they noted in their studies. They also found that a lot of the psychiatric impairments appeared to persist with age and sometimes even increase with age. And so I guess intuitively that makes sense. You expect as a child moves through later childhood and adolescence, a lot of the demands placed upon them in the environment could exacerbate some of their mental health problems, and adolescence is a risky time for anybody, let alone for a child with FASD and whatnot. So their overall conclusion was that the impairments in FAS or FASD lead to very serious problems with life adaptation. Jackie's going to talk about that, how this can lead into problems with how they function in society and how they adapt to society, resulting in a large proportion of them being dependent on external support. So this is a pretty serious concern. These are very prevalent mental health problems, and they significantly affect the lives and the outcomes of these individuals. So again, this goes to show that we're really seeing almost the same thing across the ocean as we are seeing in North America. There have also been a few studies that have looked at adults with FASD. In one study, they found that among adults, prenatal alcohol exposure was associated with alcohol problems, which is considered a mental health problem, according to the DSM-4, as well as increased psychiatric disorders and traits. So that study was by Barr et al. In 2006. One of the very few Canadian studies, I'd like to highlight some of the Canadian data, conducted by Clark et al. They looked at adults with FASD, and in their study they found that 92% had a mental health disorder. Again, almost the exact same prevalence as we see in Streisketh, they're 90%, and the 87% in, I think it was the O'Connor study. So very high rates, and now we're seeing, it's just similar rates across many different countries. And again, they found the most common to be ADHD, which again we found in the previous study, depression and panic disorder here. So ADHD turns out to be, a very significant mental health comorbidity or mental health problem among those with FASD. Another study conducted by Grant et al. In the United States, where they followed adult women with FASD, and they found that the psychiatric problems among these women really significantly reduced their quality of life. Related to mental health is suicide. And there's very little research on suicide in FASD, but there are a few good studies out there, and I wanted to highlight those. There's anecdotal evidence that the suicide rate may be higher among individuals with FASD, but there isn't tons of data out there, but there are a couple of studies that I think are really important to highlight here. In that Streisketh longitudinal study, where she followed those 415 individuals for 30 years in that longitudinal study, of the adults in that sample, there were 415 individuals, 90 were adults. Of the adults in that sample, they found that 23% had attempted suicide. So that's a very high rate. That's more than 5 times higher than the US average. Okay. And that's obviously a significant concern. We also know that 90% of the sample had mental health problems. So mental health problems were likely very linked with the suicide attempts. Later, Huggins et al. Did a study to look specifically at risk factors for suicide and protective factors. So they suggest that FASD may increase the risk for suicide, which based on the Streisguth study, it looks to be that way, but of course it's just one study. So what they did is they looked at risk and protective factors among 11 individuals with FASD, 6 who had attempted suicide and 5 who had not. So it's a very small sample of individuals, and as you can see, this is probably very difficult research to do. And they just looked at these 11 individuals to look at, are there factors among those 6 who attempted suicide that separate them from the 5 that didn't? So are there things that would either lead to suicide or be a protective factor against it? So I guess really not that surprisingly, those who had attempted suicides were much more likely to have a mental health disorder, which again just really ties the link between the mental health problems in FASD and the link between suicide and mental health. But they also are more likely to have a substance abuse disorder, which could be overlooked here, which I think is really important. Again, substance abuse disorders are considered mental health issues, and again, both of those led to increased risk of suicide. Also, having a history of trauma or abuse was much more common among those who had attempted suicide. And again, that supports what they found in their previous research, where not being exposed to violence was a protective factor against all secondary disabilities. So as you can see, abuse and violence is a really significant problem among FASD, and it can lead to many negative things. So being able to prevent it and remove children from those situations is obviously very, very important. Interestingly, this was adults. Financial stress was a big predictor of suicide, and I'm not sure about the predictors of suicide in the general population. Maybe Jackie can talk to that if she has that data, but that was a predictor among this sample. And then low social support, and I think that's really important. So those who had less resources, less of a network, less people to rely on, again, were the ones that were more likely to commit suicide or to attempt suicide, sorry. So very, very little research on suicide with FASD, but what we do have out there suggests the rates may be higher based on these 2 studies, and there may be some specific factors that are more likely to lead to suicide attempts. So based on what I've been talking about so far, most of the research on mental health problems in FASD is conducted on people with a diagnosis of FASD or individuals with significant amounts of prenatal alcohol exposure. So these are people that are very at risk. They've been exposed to significant amounts of alcohol exposure, enough to warrant an FASD diagnosis. However, there's very few studies that have looked at very low levels of prenatal alcohol exposure, but one study, Sayal et al., did look at this, and they looked at the relationship between very low levels of prenatal alcohol exposure, actually less than 1 drink a week, which was considered a low level of prenatal alcohol exposure. And they looked at how that predicted mental health problems in children. And what they found that less than 1 drink a week in the first trimester, when some women don't even know that they're pregnant, was associated with significant mental health problems among girls at age 3 and age 6. These are very young ages to be documenting mental health problems, and to show a significant association with such a small amount of alcohol. This was a really compelling study, and they had a very large sample size. It was a very well conducted study. So again, this is very preliminary data. There aren't a lot of studies on low levels of alcohol exposure, but this study does indicate that low levels may negatively affect mental health problems among children, and we don't really have much research on low levels among adults as of yet. So that just kind of gives you a background on the existing research on mental health problems in FASD. We did try and review most of the studies. There's probably a few that we didn't review, but that was the majority of the studies that have been conducted on mental health problems. And now what we're going to do is I'm going to talk about 2 of our studies that we've conducted here in Alberta with an Alberta population looking at mental health problems. So the first one is with children with prenatal alcohol exposure, or FASD, and the second one is with adults. So the first study, it's actually part of a much larger study. It was a retrospective analysis of clinic data on children who had been assessed for FASD at a hospital FASD clinic at the Glen Rose Rehabilitation Hospital, where my research lab is located. And so we did a retrospective analysis of the data on those children. one thing we looked at was mental health problems, but we looked at a number of other things. This is a part of a larger study. So the files were reviewed for 96 children who were assessed for FASD at a hospital FASD clinic. This was a retrospective study on anonymous data, so we were able to review all of the files for all of the children diagnosed within a specific time period, which I think this was 2005 to 2008 that we looked at. So it's not, we didn't just only have those children that gave consent to participate. We actually had the whole sample during that time, which is actually really important because this is the sample representative of those diagnosed with FASD over a 3-year period. It's the total sample. The average age was 4 to 17, the range was 4 to 17, in which the average age was 9 years. So we have a pretty broad age range here, and that just reflects the range of ages that children can be diagnosed at. Out of those 96 who were assessed for FASD, all of the 96 children have prenatal alcohol exposure. In order to be assessed at the Glen Rose Hospital, all of the children must have documented prenatal alcohol exposure. So we know they're all exposed to alcohol. Out of those 96, slightly more than half, 52, went on to be diagnosed with one of the disorders falling under the umbrella term of FASD. And the rest were not deferred, or were not diagnosed, or were deferred to be later assessed. So just to make clear here, these 52 had FASD, the other 44 still had prenatal alcohol exposure. Okay? And some of them were just too young to get the diagnosis. Some of the children under 6, it is very difficult to give the diagnosis to, so sometimes they will defer them to be seen later. So again, all exposed to alcohol, about half of them had a diagnosis. And what we found here among children was 74% had a mental health comorbidity. Now, this is obviously a very high rate, pretty similar to the 87% and 90% that we're seeing in other studies. But again, in this study, we only looked at those who already had a previously diagnosed mental health disorder. We did not go and measure mental health problems among all of these children. So it could actually be likely higher than this, that there's children in there that have mental health problems, just didn't have a diagnosis of it when they were assessed at the Glen Rose. The fact that 74% already had a diagnosis, that's a really, really high percent. Okay, so this is among the children. I'm just going to go over the different mental health diagnoses that we documented in our sample. The blue bars represent children with FASD, and the red is what we would expect based on the norm or average, and these are based on stats from the DSM-4 or other research studies. So if there were a few different studies that had a few different rates for these mental health problems, we took the average of them. So as you can see, which actually supports previous research, the highest one was ADHD. As you can see, almost 60% of the children with FASD also had a comorbid diagnosis of ADHD, which is a mental health disorder, or part of the DSM. And as you can see, the rates of ADHD among children in the typical population are around 5%. So obviously a significant group difference there, much, much higher. Very interestingly, the second highest, which, based on this graph, the way that it's scaled, makes all the rest of these look quite low, but they're actually not that low. These are still, very high rates and quite significant. About 15% of the sample had a diagnosed reactive attachment disorder. Jackie will go into a little bit more detail about what reactive attachment disorder is, but we actually don't have a red bar here because there aren't any really good prevalence stats yet on reactive attachment disorder. I found one website that said 1%, but I didn't want to put that in because it was one website, it wasn't a published document and whatnot, so this is obviously much higher than we would expect in the general population. Post-traumatic stress disorder, again, we saw about 12.5% that had that, and these are children, so post-traumatic stress disorder is a pretty serious diagnosis for these children to have, and again, higher than what we would see in the normal population. And then you can see anxiety, depression, and behavioral disorders were the next most common ones. So I just want to underestimate here that this is based on a file review on diagnoses that the children already had. We didn't go and measure these things. Had we gone and measured anxiety in all of these children, we likely would have even seen a higher percent that actually met the criteria for an anxiety disorder. We actually looked at some other age and gender effects to see whether or not those impacted the diagnosis. And we found that older children are more likely to be depressed than younger children. I guess, which isn't that surprising, with some of the difficulties that come with adolescence, and particularly adolescents with FASD can be a very difficult time. And we found that younger children were more likely to be diagnosed with ADHD than older children. So those are the only two age effects that we found. And we looked at gender effects across all of the categories there, and the only one we found was boys were more likely to be depressed than girls. And that, that was an interesting finding. It was significant. It wasn't a huge group difference, but it still was there. And this wasn't because the boys were older. This is even when you take into account age, boys were more likely to be depressed than girls. So, good. So the next study I'm going to talk about is on adults with FASD. And in this study, it was a retrospective analysis of data on adults who were attending the step-by-step program at Catholic Social Services. So, I'll just go into it here. The step-by-step program is a program that provides support to parents who have prenatal alcohol exposure or FASD who are currently parenting. And the program is to assist them in their parenting skills. So we've been working on a community-based project with Catholic Social Services to evaluate the step-by-step program as well as 3 of their other FASD programs. So this is kind of a snapshot of data out of one part of one of the programs. Again, this is part of a larger study that wasn't necessarily focused on mental health, but focused on the overall program outcomes. Okay. So we had retrospective data on 24 adults who had participated in this program, who had pre and post data in the program, 23 females and 1 male, who either had FASD or prenatal alcohol exposure and who were currently parenting children. The mean age was 30, age range from 19 to 47. So half actually had an FASD diagnosis, and half were suspected of having FASD, or had prenatal alcohol exposure, or had kind of mixed history or mixed evidence of prenatal alcohol exposure. The program actually assists many of the individuals in this program in actually obtaining an FASD diagnosis while they're in the program. But what we found among this small sample of adults was 88% had a mental health comorbidity. Again, almost the exact same number that we see in the studies in Germany, the studies in the States, the other study by Clark et al. In Canada. Very similar rates of near 90% having mental health comorbidities. In this example, 71%, we also had information on their abuse, had also experienced abuse. Now remember, in the Streisgott study and in the suicide study, being exposed to violence or being a victim of abuse was a very high risk factor for mental health problems or suicide. So you can see that these two are probably very, very much linked. When we look at the different types of mental health problems, so this column here shows the mental health rates among our sample of adults with prenatal alcohol exposure or FASD. And the next column shows the rates that you would expect in the general population based on the DSM-4 criteria. So 50% were clinically diagnosed with depression. That's as compared you'd expect 5 to 9% in the general population. 42% had ADHD. You'd expect probably 3 to 7% among adults. These are adult stats here. Anxiety and panic disorder, again, we found 38% of the sample had this, as compared to 3% in the general population. Post-traumatic stress disorder, 25% of the adults were diagnosed with post-traumatic stress disorder. A quarter of them had this diagnosis, a very significant diagnosis, as compared to 8%, which was the lifetime prevalence. Cognitive delays was 25% of our sample, as compared to 2 to 10% of the typical population. Interestingly, Tourette's syndrome, this is a small sample size, so we found 8%, which is only 2 people, but the rate of Tourette's in the general population is actually much, much lower than that. So I think we obviously need some more research maybe on the connection between Tourette's and FASD to see if other studies are finding higher rates, because this is just one study and there's just 2 people that had it. So just take that as it is. And then here, self-harm and suicidal issues were 8%. Oh, okay. So something is cut off. Oh, is that what it says there? I can't see. Okay.
Yeah.
So we didn't really have a combined rate for self-harm and suicide together in the general population. And I think that the rate of 8% here is probably likely very much an underestimate, because this was only whether or not it was documented in the files. We didn't go and interview these individuals to see if they were suicidal, to see if they had ever self-harmed themselves. It was only if it was directly stated in their files. So all of these, and then there was the other category. All of these is similar to our previous study. If we actually went and measured their depression and measured all of these things, all of these probably would be actually higher than we actually found here. But again, it goes to show that, like I said, 88% had a mental health comorbidity, and we see very high rates, depression, ADHD. We see similar findings as we found in the United States research. Okay, so that brings me to the end of those 2 research studies. Now I'm going to turn it over to Jackie for the last half of the presentation.
Excellent. Thanks, Carmen. So, that's it. We're going to now open for questions. One thing I want to say right at the very end here, I'm just flipping ahead to our contact information. There's one mistake on here, just if people want to write it down. In case you want to contact me, my email address is Jacqueline, just as it's spelled there, JACQUELINE, .PEI @ualberta.ca. So you need to add in the period and my last name to that, and then you'll have access to me. So otherwise you're going to be emailing this address to no avail, and it's not just me being rude. So, well, it might be, but it's probably not. So Jacqueline.Pye. And I think that's up for questions, and I don't know who facilitates that.
Yeah, do we have questions? We do, actually.
Oh, wow.
So this question is on medication for depression, and she wants to know what are some possible side effects, if there's any red flags of adverse side effects, how long does it take for the medication to start working, and what might cause the opposite effect of the medication in somebody. So
Yeah.
they become hyperactive
All right.
and irritated.
So the question is around medication. First of all, I'm not a physician, so I'm not the best person to answer this question. So I want to qualify it. I do work with physicians. Once again, this is this communication piece, and I think it's very important. But I am not a physician, so when it comes to talking about side effects and specific issues, I'm not the person to do that. What I will say is that we do sometimes find that medications that may work typically in the population may work differently in an individual with FASD, because we are dealing with brain injury, and we're dealing with brain injury that takes place at a developmental level. So some of essentially the wiring in the brain is different. So there are times when I see antidepressants work beautifully, just as I would expect them to work with anyone else. There are other times when I see nothing, no effect whatsoever, and other times when it does produce greater problems, and functioning is more impaired, and that really comes down to some very good communication between myself, physician, whoever's directly involved with the individual's care. What I suggest, I guess, around that, like I said, not being a physician, I don't want to comment too much on the specifics of medication, is really working closely with the prescribing doctor to kind of oversee that, really encourage that when that medication is being trialed, that it be monitored closely. Antidepressants typically take a long time before we start to see real impact. So you're looking at about a month before you're going to see an impact, generally speaking, in terms of an antidepressant medication, although you could see a side effect sooner than that. So I know I'm not really directly answering the question, except to sort of, I guess, throw up the caution and say I'm not opposed to medication, but I really strongly endorse a teamwork approach when we're doing it. Again, also, FASD individuals are not always great advocates, and so sometimes we need to be sure that there is an external support person who's also helping to monitor the impact of the medication on their functioning, not just them, because they may not always recognize when something is going wrong, if it is going wrong, or that something's going right. So it is just good to have a good system with that person. Thanks.
Any other questions?
Yeah.
Nothing else has come.
Wow. we just answered everything so well.
Usually it comes in after.
Well, and,
So
and,
you'll
and
get the
everyone,
emails.
yeah,
Okay.
and send us email. I mean, both Carmen and I are really happy to answer emails and to go through, if there are specific questions or specific challenges you might be facing in your specific site or area. I think we're both very happy to look at those questions and at least do the best shot we can get back to you.
Awesome. Perfect. I'm just going to close. Carmen and Jackie, thank you very much for a fantastic presentation. Mental health is a critical component, I think, to FASD, and I think Alberta has struggled with really pushing the agenda of mental health, and so we're pushing hard through the video conferencing series to put mental health in the forefront. Again, we really support your push for across the lifespan approaches, which the Cross Ministry Group is really pushing hard on, because these transition periods are so critical for the individual. So thank you very much. As always, it's lovely seeing you ladies. Just a few other things. The evaluations will be mailed to participants within the next 2 business days, so please ensure that you sign the attendance sheet. Your feedback on the various sessions are really critical, so that we can keep the video sessions ongoing. The next session is with Dr. Kieran O'Malley, and he'll be presenting on FASD and mental health treatment, looking at the transgenerational focus, and it's scheduled for Wednesday, May 13th at 9 a.m. As you know, all sessions are recorded and stored on the CMC website. That address is www.fasd-cmc.alberta.ca. And so usually within 1 or 2 weeks we have these sessions available to people on the website. Once again, thank you very much for joining us today.